Myofascial trigger points, because whenever you come to SPARRC, they're constantly using the word, this is myofascial trigger. And we don't seem to be hearing this word or seeing this word so often in other places. How come this is so different? So myofascial trigger points are painful spots on the muscle. We live our life through our muscles. We move, we do everything through our muscles. We emote through our muscles. So naturally, whenever the muscle is overloaded in any dimension, physical, mental, social, emotional, um, psychological, in all these levels, we can make changes in the integrity of the muscular tissue and its performance. So myofascial trigger points can happen on a muscle fiber which becomes tight and painful and thereby causes pain, swelling, altered sensation, tingling and numbness, sometimes lacrimation, sometimes salivation, increased salivation, giddiness, vertigo, loss of balance, coordination. Like this umpteen number of things that are possible because the myofascial trigger points can involve the autonomic nervous system also. So when we are dealing with the myofascial trigger, it can happen due to a fall, injury, accident, surgery, which is going to be an acute or the precipitating factors. The perpetuating factors are chronic. What I mean by perpetuating factors, which we feel will not cause pain, like sitting and working for a long time and trying to ensure that you tilt your head to protract your neck to ensure you achieve your vision on the monitor. Commonest reason for these pains are on a laptop, cell phone, computer, TV, or reading for a long time. Commonest reasons to hold the part of the body in a particular space for a long time and thereby demanding the postural groups to work more than what they normally do and failure to breathe during the time, another important component. So when we are looking at these myofascial trigger points, we are looking at biomechanical causes, biochemical causes, psychological causes, sociological causes, and that's why the question is also asked regarding all these levels that are involved in our day-to-day life, but in a very subtle manner. In fact, the number of patients that we see following an injury, accident, sports injuries are only 10%. 90% of the people who have never moved their body for any kind of exercise but sitting and working for long hours. So understand myofascial trigger points are ubiquitous from the pediatric to a geriatric age group, from men and for men and women, and for whether they are old or young. It can happen in any kind of people from all walks of life. And the commonest one that will be seen even in the presence of fracture, even in the presence of other organ involvements like renal calculi or diagnosed as a torn muscle, there also we'll be seeing the myofascial. So these trigger points, once they are reduced, can be prevented from forming through the exercises that we prescribe. So we release them manually, that's why it's slightly painful. And we ensure that once the pain is under control, bring in the exercise component to ensure that the muscles can be restored through your effort. We ensure that at SPARRC you are an active participant in the treatment, not a passive recipient. We are not dependent on the pharmaceutical agents or the surgical intervention to achieve the result. We are dependent on the individual themselves creating the pharmacy within, and that is through your exercise. So when we are looking at a myofascial trigger points, when they complain of a shoulder pain, not being able to move the arm, okay, they find, yeah, it's painful, okay. So what we do is we search on the, not the shoulder joint alone, above and below the shoulder joint to ensure whether it involves the muscles that participate further away from the shoulder, neck, elbow, wrist, hand, etc. So myofascial is not only at the spot that we are treating the individual. So when they complain of a shoulder pain, I may hold around the elbow region, and now the pain is much less. Wow, this is what you're going to see with a myofascial trigger. We are holding the trigger points and understanding through the patient's participation, and they are able to give a subjective um, reference to the level of reduction in the pain. I don't say that it is not an objective component, it's a subjective component. How the patient feels that now the pain is less. When I touch that region, the pain is so much, but when I make the movement, patient finds that the pain is very minimal. Only the sight is painful, the movement has become pain-free. These are the issues that we need to understand. Somebody who is not able to bend forward, sir, if I bend forward, it will be very painful, sir. So the minute I hold the muscle which is involved in the movement pattern, the movement is now pain free. So an individual who says, I can't bend forward. Now the minute I hold the muscle, they are able to go down fully and come up. A person who is not able to cough or sneeze, I hold a particular group of muscle, now the coughing and sneezing is pain free. So this is how we identify a myofascial trigger point and make the patient understand that this is nothing from the disc or a nerve compression or a major organ involvement, but it's a local muscular issue that can be fixed. Thank you.